All right, good morning. Good morning. I'm Dr. Tuna, and Dr. Manuel Matos is helping me today. We will be talking about the volar forearm anatomy. I have already lifted the skin for ease of dissection. So this is basically from the wrist crease. The wrist is to the left of the screen, and the elbow is to the right of the screen. So we will dissect from the cephalic vein to the basilic vein and look at the structures on the volar forearm. Now, on the most radial part of the distal forearm and mid forearm, the cephalic vein shows, and it nicely starts about the dorsal-radial side of the wrist, and it goes medially toward the antecubital fossa. About one interesting thing is these superficial nerves that accompany the radial nerve. Cephalic vein, and there must be another one dorsally as well. But there are, so you can see another one about here that will follow the cephalic vein. So when you see the vein, be careful. Now, as we go proximally at about 2 fingers, 2 maybe 3 fingers distal to the elbow flexion crease, we see the relation of the anterolateral cutaneous nerve of the forearm and the cephalic vein. Usually we see the cephalic vein and then look for the vessel during a surgery around the proximal volar forearm. This could be a pronator teres release, or it could be a biceps tendon surgery. But first you see the vein, and then under that you will find the anterolateral cutaneous nerve of the forearm. And this is a nice, this could be a nice nerve graft in case you need nerve grafts as well. So the anterolateral cutaneous nerve of the forearm is continuation of the musculoskeletal musculocutaneous nerve. You can see it comes lateral to the biceps and gets into the forearm. So let's cut that, and then let's try to find the second cutaneous nerve that we usually encounter in the forearm. The second one is on the medial side, and it's called the anteromedial cutaneous nerve of the forearm. And here it lies on the common flexor origin, and you can see the superficial nerve that is going toward the ulnar border of the forearm, and inserts at about the area, well, disperses at about the area, or innervates the area between the FC and ECU. And this nerve is quite important because if you remember ulnar shortening, you will encounter this nerve when you're approaching the ulna between the FCU and ECU, and this is the nerve to be dissected and protected if possible. If not, then you can cut it away from your incision. So if we look at this from outside, then this is basically where we are. So this is exactly where we make the incision on the ulnar border right in here, and that's the medial cutaneous nerve of the forearm that or anteromedial cutaneous nerve of the forearm. Now, as we approach the deep layer, now we see the deep fascia, which is again quite thick, and basically it wraps around the muscles in the forearm. Now, as we approach this, we see the perforators from the ulnar artery here that are going to this skin, and there were perforators on the radial side that were coming out as well. These perforators are important in doing the ulnar artery flap. Now let's go to the distal forearm, and then do a little more dissection and start ulnarly, and then go from ulnar side of the forearm to the radial side of the forearm. Now, as we approach here, we see that the FCU is very superficial, and I can expose it right in here, and it is the most ulnar muscle of the forearm. Now, interestingly, if you look here, right about here, we should be able to, let's look for the vessel that supports the dorsal ulnar artery flap. It should be about 1 inch, within 1 inch from the pisiform, and I believe the bleeding we have here is from that vessel. So we should be able to see, if you look here, right in here. This is not an injected specimen, but right in here, right in here is the vessel to the ulnar border of the forearm. Now here's the FCU. So normally you would put a retractor here and then explore that vessel, and then at about 2 to 3 centimeter proximal to the pisiform, we should be able to see it. But I believe it was cut and the bleeding was from that vessel. Okay, well, so here's our FCU. FCU is an interesting muscle because it has very short fiber length. That's why its excursion is not too much. It's about 3 centimeter, and this is partly because of the, mainly because of the insertion or origin from the ulnar border. If you look at the FCU, it really has two areas of origin. One is the distal humerus, and the other one is the ulna, and that's how the muscle arises and comes distally to insert onto the pisiform and the fifth metacarpal. Now, if you elevate this, then this will give us a good access to the ulnar nerve and ulnar artery. Now, it's very important to understand that relation between the ulnar artery and ulnar nerve here to be able to do nerve block, a wrist block. If you look at this relation, the ulnar artery is superficial and radial to the ulnar nerve. So if you palpate when you're doing a nerve block, if you palpate the FCU tendon and palpate the pulse of the patient, your needle goes right between the FCU tendon and the artery, and it should go deep to the artery, but not too deep to get into this compartment, which is the deep layer right in here. And if you get into this deep layer, then you will be injecting all your material into the flexors, and it will be very difficult for that to get in to the ulnar nerve. And also there is a sheath, a flimsy layer between the FCU and the ulnar nerve, and if your needle gets too ulnar, you end up injecting the FCU, and again you will miss the ulnar nerve. That's why you should aim at right between the ulnar nerve and between the FCU and ulnar artery, and to keep this to keep the whole anesthetic within this fascial layer, to be able to achieve a successful ulnar nerve block. And I think this clearly shows that sheath I'm talking about. We can put this so you can really see it better. So let's go with the muscles. In the forearm, there are superficial muscles and deep muscles. The superficial muscles include if you put your hand in that position, the index finger goes with the pronator teres, the long finger goes with the FCR, flexor carpi radialis, and then the ring finger goes with the palmaris longus, and the small finger goes with the FCU. So if you look at the anatomy here now, so the first muscle, the first superficial muscle is the pronator teres, which originates from the common flexor tendon and inserts to the mid forearm radially. The second one is the FCR, again originates from the common flexor origin and then inserts to the second metacarpal base and maybe a slip to the third metacarpal. Then the third muscle is the palmaris longus, which originates from the common flexor origin and inserts to the palmar fascia. And the final superficial muscle is the FCU muscle, which originates from the humerus and the ulna, again from the some of it from the common flexor origin, and inserts onto the pisiform and the fifth metacarpal. Now, as we approach this, we can see the fibers even better. And right here, it's coming from a common tendon. Right here, you can tell this is the common tendon between the palmaris longus and the FCU. So let's dissect up to here. There are many branches that are going into the FCU at this level, and look at the muscle and look at these fibers. And the excursion of a muscle is directly related to the muscle fiber length, and these are, if you measure it, it's about 2.9, maybe 3 centimeter in measurement. So then we can just elevate this of the ulna, and then proximally you can see the origin right here between the palmaris longus and the FCU. So this tendon right in here, this origin tendon right in here is really the it's a shared tendon. From this side, palmaris longus originates, and from this side FCU originates, and right under that is the ulnar nerve. Now proximally the ulnar nerve um, if you remember cubital tunnel anatomy, the ulnar nerve goes under the Osborn ligament, and then it goes under the FCU aponeurosis, and then it will come to the mid forearm, and then about the mid forearm, about this level, we should be able to see the ulnar artery. So the ulnar artery takes off from the brachial artery, and then will go medially toward this border, and at the mid forearm level, somewhere here, we should be able to see the ulnar artery. Let's look for that. So let's come from proximal to distal. And exactly right here, I can start seeing the radial artery in close relation. Right in here, you can see this is the ulnar artery, and this is the radial artery. Now the ulnar artery goes distally between the superficialis and flexor carpi ulnaris, and right about here it gives a branch. Remember, if an artery is thrombosed, it thromboses all the way up to the next branch. So in a syndrome like ulnar hammer syndrome, hypothenar hammer syndrome, we find a clot in the superficial arch, and then you will have to dissect the whole Guillaume's canal, and then it goes all the way down to the first branch, and that's usually the dorsal ulnar artery branch. So when you reconstruct that, then you cut somewhere here, and then bring it all the way down. And in the same incision, you can identify the cephalic vein to take it as basilic vein, to take it as a vein graft. Now, the second muscle from ulnar to radial, and that is superficial, is the palmaris longus. Let's move distally and look at the insertion of the palmaris longus, and it has a sheath on its own. Palmaris longus is the most commonly variation, let's say the muscle that has the most common variation. It's present in 90% of the time, and as you can see here, it has its own sheath right in here. There's a sheath underneath, and there's a sheath over it. So what we do is we use this tendon many times as a tendon graft. We make a small cut in the volar forearm, and then would detach it from its insertion on the palmar fascia. Then we will put a tendon stripper that would take the tendon all the way up to the proximal forearm, and detach it in the proximal forearm. So that's how this muscle is harvested. So this is a nice tendon in this specimen that has a long tendon and has long muscle fibers and very nicely detached. Now, on radial to the palmaris longus superficially is the FCR. And you can find the FCR on the radial side, and FCR, the flexor carpi radialis longus, is a median nerve innervated muscle that has its own sheath. When we harvest the FCR for CMC arthroplasty purposes, we make a small cut in the sheath and then lift the sheath of the tendon, and then would put a wire that travels all the way down to the second metacarpal area, and this is the layer that you need to. This is the layer that you need to put the wire in. If you keep it over this, then you will get lost distally. As you approach the distal forearm, you will see even a thicker tendon sheath. Now that can be used during a distal radius surgery. So we'll come to that in a second. Now in approaching the distal radius, an anterior Henry approach can be used, and that is basically between the radial artery and the flexor carpi radialis, but there's a modification of it which stays between the brachioradialis and the radial artery, but there are many branches that go to the brachioradialis on the radial side of the radial artery. That's why that's not a good approach to use. Instead, we go between the flexor carpi radialis longus and the radial artery. However, closure is a big problem then, and putting stitches and trying to close the tissues usually require passing a not required, but accidentally you enter in the radial artery. That's why a better way is to open the FCR sheath and then retract the flexor carpi radialis medially, and then this will give exposure to the dorsal part of the sheath, and then as you open that dorsal part of the sheath, that will bring you between the FPL and the radial artery, and that as you approach this, as you pull the flexor pollicis longus, then that will give you that will bring you down to the pronator quadratus, and we will come back to the pronator quadratus to complete our dissection there. Now let's detach the FCR as well and pull this muscle proximally. Now you can tell that all of these muscles are attached to each other proximally because they all originate from a common flexor origin, common flexor pronator origin, you can call. And these are mostly median nerve innervated muscles. Now, as you look at this big muscle bulk, this bulk of this is basically the flexor digitorum superficialis muscle. Some people call this an intermediate layer, or some will take this as part of the superficial layer. But several origin tendons will form in the proximal forearm, and I'm detaching the palmaris longus. Basically, it's coming from a box-like origin. You can tell there's a tendinous origin here, and let's remove this muscle completely so you can look at the wide area of origin. So this side, and bottom side, they are all form an origin for this muscle, and and the same is true from this muscle, pardon, this tendon. The FDS originates. Now the FDS quickly, from that common origin, FDS quickly changes into two superficial tendons, as you can tell here, and two deeper tendons, and these superficial tendons go to the, if you take zoom out please, this will be the ring finger FDS, and then the radial one will be the third finger FDS. So so this will be the third finger FDS. So 3 and 4 sit quite superficially, whereas 2 and 5. So this is the 2, and then 5. I guess I'm pulling the, maybe this patient doesn't have the FDS to the 5th. Let's see what this is. Yeah, looks like she doesn't have an FDS to the 5th. Or maybe it's later. Maybe underneath. It is, maybe this is the 5th. Okay, let's see if this is it. It's a very small, yes. So this is the, it's a very small tendon. If you can zoom in here, it's a very small tendon that separates from the muscle and goes to the FDS to the small finger. Okay, so now we have dissected that as well. Now between the flexor carpi radialis longus and the median nerve, between the flexor carpi radialis and the flexor digitorum superficialis goes the median nerve distally. And if you follow me on this median nerve, you can see the median nerve comes under the FDS, and then will give the palmar cutaneous branch right in here, and will go under the transverse carpal ligament. Now the palmar cutaneous branch takes off about 5 centimeter proximal to the wrist crease. And right in here. So for a high median nerve block, you can inject between the FCR tendon, which is here. You can palpate the FCR and the palmaris longus, and then you can inject about 6-7 centimeter proximally, and right between the palmaris longus and the FCR. We didn't look at the ulnar nerve dorsal branch, so let's move back to that ulnar nerve and try to see if we can show the ulnar nerve dorsal sensory branch. So that should be taken off about 5 to 8 centimeter proximally. So the area we should look at is somewhere here, and here is our nerve. That's exactly where it is. It's right here. So it's a huge nerve, and this can get injured during a distal ulnar surgery as well. It's very and it's really a big nerve. Right in here, look at that nerve. You can see. And this seems to be the an artery accompanying them. It may be the dorsal ulnar artery, but at this point I wouldn't comment on that. Okay. Now let's go proximally. I would like to show you the pronator teres. And maybe a pronator teres release to see if there's any arcade forming around the median nerve in the specimen. So we make an incision about 2 fingers distal to the elbow flexion crease, and the scalpus fascia is passed, and the structure that we will encounter is the artery, the cephalic vein, and the cephalic vein and the anterolateral cutaneous nerve of the forearm are retracted. Then this gives access to the lacertus fibrosus, where you see these branches right in here. These muscle fibers are all lacertus fibrosus, and then you can make an incision along with the pronator teres, and you see the lacertus fibrosus insertion right here, and cut this one. So you don't have to make a separate incision for that. It's just part of it, and you can just detach it like that. And then that gives you access to the brachial artery right in here, and the accompanying veins, and that will give us a nice exposure of the median nerve. And in this specimen, the median nerve seems to be quite superficial. Thank you. And then right in here, as we dissect, the median nerve goes under the pronator quadratus, but let's see what we have. So here's the median nerve, and here's the pronator quadratus, and I don't really see any arcades yet. So this looks pretty normal to me. And there's really nothing all the way down to the superficialis muscle, and I don't see any arcade, but a couple tendons right here on the radial side, but I don't really see any arcade to be compressing. Maybe this one right in here. Yeah, this is interesting. Maybe this one is there. Yes. So this I mean, in a pronator surgery, I would absolutely release this tendon over that nerve. We sometimes see an arcade about here that forms around the median nerve, and it's such a tight area that would put the nerve down and would irritate the nerve. Now let's move on to the so this is the FCR, and then I will let's see what we've got here. So I'm separating the radial artery, and we should be and right in here you can see the common origin for that muscle, and you can tell the pronator teres goes radially all the way to the mid arm level. Mid forearm level, and it goes and it's innervated by the median nerve, and its main function is to pronate the forearm. When you're doing a tendon transfer for the radial nerve palsy, pronator teres is a nice muscle to transfer to the extensor carpi radialis longus, and you can always harvest it with a little bit of extra periosteum, as it has a broad origin, and you can incise the periosteum and then elevate this muscle with that, and then bring it proximally. So this branch that I just cut was the branch to the pronator teres. That can be used in neurotization. Neurotization of the ulnar nerve about here. Okay, so so the arcade that we just cut was I think it was this one about here, and it was an arcade within the superficialis. Then the median nerve really goes nicely between the FDS and the FCR. Now, as we retract the superficialis muscle, then we will be seeing the FDP. FDP is flexor digitorum profundus, and this goes to the fingers and inserts on the distal phalanx, and you can see the little independent second FDP, but the third, fourth, and fifth are very closely related, on the way the flexor digitorum profundus gives rise or sits as an origin tendon for the lumbricals as well. Now the second and the third FDP is innervated usually by the median nerve, and the fourth and fifth are usually innervated by the ulnar nerve. So if you have an ulnar nerve palsy, then the second and third FDP are still functioning, and you can do a stitch by basically tenodese these four tendons together, or if you would like to have a separate function for the second, then you can tenodese third, fourth, and fifth by stitching to each other, and you can motorize the ulnar nerve palsy, and that would bring us to the all the way down to the ulna again, as we separate between the second and the third FDP, and you can palpate the ulna and the interosseous membrane in between. Now the other muscle of the deep layer is the FDP, and FPL. FPL is flexor pollicis longus, and this is the only muscle that originates from the volar border of the radius, and you can see how it attaches to the FDP to the radius in the mid forearm, and that was the nerve to the PL, and then we retract the FPL. Now, during a distal radius surgery, we retract the FPL, palmaris longus, and the median nerve medially, and we expose the pronator quadratus tendon, and that is right here. It's a flat muscle that originates from the ulna and these small tendinous fibers, and inserts on the radius, and most of it is really muscle, and you don't see any tendinous fibers. That's why you cannot repair the pronator quadratus muscle. Even if you attach these two with the first pronation and supination, it will tear. So I find those efforts useless. You can see now right here. I can see a arterial branch to the FDP, I'm sorry, to the pronator quadratus, but it's really off the bone. So let's see if this probably contributes somehow to the radial, I'm sorry, to the volar carpal arch. As we approach the lip, the volar lip, there's a. Can you zoom? There's another. This is unfortunately not an injected material. That's why it's not easy to show these vessels. But the branch of the radial artery to the carpal arch goes right at the volar lip, and that is the vessel to be used for a radial for a volar bone graft, for a volar radius bone graft. Now, it yeah, you can't see it, but right in here I can tell that was an artery, and it gives a branch going down, and you can take it from the ulnar side of the volar radius. Okay, well, are there any questions? This is all I wanted to show. You can look at the maybe brachyradialis relation between the radius and the brachyradialis as well. Right in here is the first compartment, and under that is the brachyradialis. Right in here, as if it shows as a flat tendon. Right in here. Okay, any questions? Absolutely. Yes. Okay. What do you want me to show? Tell me again, please, because of the noise here, I couldn't hear exactly. Do you want me to show the radial nerve, how they cut during a biceps tendon.
And we're doing a biceps repair and cut the radial nerve, and I just wanted to show the relationship that.
Okay, sure. All right. Well, that's now. First of all, I totally agree with Dr. Wolf. If you, I mentioned about that in the last week dissection. So if you have a muscle cut, you always find these layers. Like right in here, you can see this tendinous portion, and you can reattach to this, and the muscle will just heal to itself. But what I said about the pronator quadratus is pronator quadratus doesn't have that kind of a tendon. That's why we can't repair that. Only the fascia may be over it. So let's look here. Here I see the brachioradialis. I'm sorry, I said brachioradialis. I see the brachialis muscle. And here is brachial artery. Let me find the tendon though. I don't see the biceps tendon. Can you see it? Okay, so here's the here's our biceps tendon right in here, and the laterally superficially we should be seeing the antebrachial cutaneous. So right here is the musculocutaneous nerve, and then right here, as we go deep under the, so this border, remember from last week, so right this border, this is the brachioradialis muscle. So here's the antebrachiocutaneous nerve of the forearm, and here it's called musculocutaneous nerve. And then this is the vein. I just took it down, and then right under the brachioradialis we should be able to see the radial nerve. Now, Dr. Kutz, I don't know if it was a direct cut of the radial nerve, but radial nerve injuries are reported after biceps tendon repair. So it's just because of the insertion of the biceps tendon, and they thought it's either pulling the biceps tendon or it's a insertion that crosses over the radial nerve. But I remember reading radial nerve palsies after biceps tendon repair. So this is the relation. If you put a Holman retractor, I guess, about the radial neck right in here, then you may have a radial nerve. So here is the radius. So let's expose this even more. So here's your biceps tendon, and as it attaches to the distal biceps tendon, as it attaches on the radial tuberosity, right in here, and this is a bare area, and then right on the other side of the tuberosity we can see we should be seeing the radial nerve somewhere here. So here's the radial nerve from the biceps approach. It's within the extensor carpi radialis. I think it's radialis brevis muscle, or at this level it can even be in the supinator muscle. Any other questions? Can you speak close to the microphone because we hardly can hear here?